Hello and welcome to tonight's webinar. Thank you for taking the time to be here with us. My name is Robbie Robinson and I'm from Sydney North Health Network. I'm just starting on the wrong slide here, so give me a moment. Sorry about that. A little bit of an error to begin with. So we're here tonight for the Chronic Kidney Disease Management in Primary Care, the new handbook recommendations with Dr. Richard Boone. I'd like to take you through the acknowledgement of country, Sydney North Health Network, which is to acknowledge Australia's Aboriginal people as the custodians of this land. We pay our respect and recognise their unique cultures, customs, and honour their elders past, present and future, and extend that respect to the Aboriginal people attending here tonight. Just going to go through some housekeeping. So just so that you're aware, your microphone will be muted and disabled during your video will be disabled during the webinar. We would love to hear from you, so please use the question and answer functions and the chat at the bottom of your screen to ask questions and send comments. We will address those at the end of the presentation as best we can, but if we don't have enough time to get through to everybody's question, we can, Dr. Richard Boone is happy to get back to you afterwards via email. So please feel welcome to send those through. You can chat and interact with each other. You just need to make sure that you have selected to send through your chats to all panelists and attendees. Please be respectful of other participants and behave as you would in a face-to-face meeting. If your screen happens to freeze, your Wi-Fi might be limited, so try moving closer to your router. And an evaluation will be available at the end of the presentation tonight, so please make sure that you can submit that for us to adhere to our guidelines. Going to discuss a little bit about health pathways. Most of you have probably heard a presentation on that from us already, possibly even this year, but we like to talk about it at the beginning of every event where we have a live pathway that can assist in managing your patients. So Health Pathways is a joint initiative of the Northern Sydney LHD and the Northern Sydney North Health Network. It's a live online portal accessed mainly by general practitioners and health professionals and LHD staff. Sydney North Health Pathways was launched in May 2017, and we now have over 370 live pathways and over 5,000 people have visited the site, assisting with the management of medical conditions faced by the people in our region. The pathway pages include information on condition-specific local referral pathway resources, and they provide GPs and healthcare professionals access to clinical assessment, management, and referral information at point of care. If you happen to click onto a condition and the page is yellow, it may not have been localized for our region yet, but there are often other pages that are closely linked. So for tonight, chronic kidney disease, those pathways haven't been specifically set up, but there are renal disease screening pages associated with diabetes. There's a new mobile-friendly platform that has recently been made available, and it's responsive to whichever platform you're using to access health pathways. So if you're on your mobile or you're on your tablet, the pathways pages will be, they'll turn to suit your device. And lastly, logging onto Health Pathways, you do have the option to install the icon onto your desktop of your computer so that you can access it more easily. And we've also got a feedback function. So if you were to happen to go and hover over the little blue circle with the speak bubble, that will allow you to send feedback. So if there's anything you'd like to let us know about the pages that you've come across, you're welcome to do that as well. Just some contact information for Health Pathways, but we can always send that through. So if you would like to put your details in a question, I can send you through the information to access Health Pathways after this evening. Now, just an introduction for Dr. Richard Boone. Since 2007, he's been full-time senior staff specialist in nephrology and dialysis at Westmead and Blacktown hospitals. Over this time, he's held several senior clinical, educational, management and leadership roles. And my slides are covering the presentation, so I'm sorry. Honorary Treasurer of the Australian and New Zealand Society of Nephrology, Chair of the Advanced Training Committee of Nephrology, Director of the Kidney School Program, and Chair of the AHA-CARI Guideline for the Management of CKD among Aboriginal and Torres Strait Islander people and Maori. He's a long-standing member of the Primary Care Education Advisory Committee for Kidney Health Australia and has published widely on the topics of kidney disease and education in nephrology. He has active research interests in GN, immune-mediated kidney disease, chronic kidney disease, and Indigenous health. He also maintains active personal interests in family, fencing, and ballet. So I would now like to hand over to Richard. Thank you very much for presenting with us this evening.
Thank you very much for the kind introduction, Robbie, and thank you to everybody for tuning into this presentation tonight on early detection and management of chronic kidney disease, and also new recommendations from our 4th handbook from the management of chronic kidney disease in general practice. These are my disclosures. And so with regards to the aims of the presentation tonight, I'd like to hopefully provide you with the tools to how to detect at an early stage chronic kidney disease in a primary care setting, and also to optimally manage chronic kidney disease and slow or halt the progression of kidney disease as well. And so the sort of outcomes that I think we're trying to achieve tonight are looking at the importance of early detection of CKD, also looking at the elements of assessment of chronic kidney disease, particularly looking at the kidney health check, and also looking at the treatment options to delay progression of chronic kidney disease. So we might start the presentation first by handing over to a poll and asking firstly, how prevalent do you think chronic kidney disease is in Australian adults? Okay, so we'll move on and I'll come back to the answers very soon. So I've been involved in the PEAK committee for about 12 years now, and whilst I've been involved in the production and the presentation of various educational modules, I guess one of, well, if that probably the most significant educational initiative that I think has come from the PEAK committee has been the development of this handbook, the CKD Management in Primary Care. And we've now just released the 4th edition of this handbook, which is available both as a hard copy book, also as a soft copy on PDF, but also now it's available through a CKD Go app as well, which you can download from iTunes or the Google Play Store as well. And with regards to the book, the handbook, it's in its 4th edition. It was first published in 2007. As I mentioned, a few years ago, we released an app which provides a number of the different recommendations, and including the color-coded classification scheme for CKD management. Also provides a number of different guidance and clinical tips in terms of how to detect, manage, and refer patients with CKD. And also the recommendations are based on KHA-CARI. So for those of you who aren't aware, we have clinical practice guidelines in Australasia called CARI guidelines. So I've been involved in 3 of those guidelines, but also international guidelines that provide recommendations for management of kidney disease, but also other aspects of chronic disease management as well, including blood pressure management and lipid management as well. And there are various reasons why to use the handbook. It's very easy to use. We've made it as easy to use as possible. We've got a quick reference guide that's now available at the beginning of the handbook. As mentioned, and as will be discussed a little bit later, we now have a CKD staging classification that's color-coded. And according to the color-coded classification, there are clinical action plans outlining the goals of management, when to monitor patients, the key tasks, and also the frequency of assessment for these patients as well, according to what color code patients fit into. There's also medical advice in there and targets for treatment, a management framework for management of a number of different common CKD complications that could be managed in primary care. And also there are guidelines with regards to when to refer to a nephrologist. And there's also a number of different links to resources and websites, and obviously referencing for appropriate aspects of kidney management. There are a number of new aspects of the 4th edition, and some of these include blood pressure treatment targets, which I'm sure you are aware that these have been evolving over the years. There's the quick reference guide that I've already mentioned. We've also got a part in there with regards to what we call CKD hotspots. And so it's very well recognized that there are certain areas of Australia that are so-called CKD hotspots that obviously warrant increased activity in terms of how you diagnose, detect, and manage CKD in these populations. There are also algorithms and flowcharts and action plans for management. We talk more in this edition and also in the previous edition with regards to acute kidney injury. And so we talk about a sick day plan. We talk about the management of CKD in the presence of diabetes and cardiovascular disease, which obviously are highly prevalent in the community. There's also a section on kidney cysts, cognitive decline, and also the management of edema in chronic kidney disease patients as well. And we've expanded issues with regards to common issues, treatment goals, the resources and handouts that are available, and also the practice approach and the patient approach to management of CKD. So before I go on to the handbook, I think it's important to understand in the first place, well, what is chronic kidney disease? And so I think there are some important elements that you can see here on this page with regards to CKD. The first thing is that it has to be chronic. And so for both the top and the bottom part of this slide, you can see here that CKD has to be present for at least 3 months before it is actually defined as chronic. And then with regards to the kidney disease aspect, there are 2 aspects to it. You can either have kidney disease as defined by an eGFR that's less than 60, that's present for at least 3 months, with or without evidence of kidney damage, or you can have an eGFR in excess of 60, but you also have evidence of kidney damage. And this is defined by the bottom panel here with albuminuria, or the presence of hematuria after exclusion for urologic causes, or otherwise structural abnormalities. So patients in particular who have kidney imaging tests, and the prototypical type of condition for that would be polycystic kidney disease, I guess. And also pathological abnormalities. So some patients may have a kidney biopsy, even though they have an eGFR in excess of 60, and those patients are defined as having chronic kidney disease as well. So the next question, the answer in the poll, sorry, the first poll is, as you can see here, so how prevalent is chronic kidney disease in Australian adults? And it's roughly 1 in 10 of all adults aged over 18. And I think most people would be quite surprised by that, particularly by the community. They're quite surprised by how highly prevalent CKD is. So if you look at why CKD is important in Australia, these are the important aspects of it. Firstly, it's important because it's common. And so as I've already said, 1 in 10 adults in Australia have CKD, which equates to roughly 1.7 million Australians. And they have indicators of CKD such as a reduction in eGFR and or the presence of albumin in the urine. It's also important to note how common it is. And if you look at CKD and diabetes, if you take data from the Australian Institute of Health and Welfare, this is data that indicates that CKD is probably twice as common as diabetes in the Australian community. And then finally, if you look at the risk factors for CKD that I'll be coming to a little bit later, you can see here that 1 in 3 Australian adults have risk factors for CKD and therefore warrant screening for CKD. The other important reason why CKD is significant in Australia is that there's a blue sky aspect, and that blue sky aspect is that it's treatable. And so you can see here that if CKD is detected early, you can lead to a reduction in the deterioration of kidney function by as much as 50%. And also we know that if you manage CKD early, you can also lead to not only reductions in the progression of or slowing the progression of kidney disease, but you can also reduce the risk of cardiovascular disease. I think it's also important to understand that CKD is often under-recognized, and less than 10% of people, according to the Australian Health Survey, are actually aware that they have the condition. And from a renal perspective, we have a registry called the ANZ Data Registry. So all patients in Australia and New Zealand have data provided to this registry that's been going on for almost 40 years now. And one of the metrics that we look for is what we call late referral. So this is people who are referred to a renal service and then start dialysis or have a kidney transplant within 90 days of that. And you would think that most people are referred at a much earlier stage, but you can see here that even from the latest figures, about 18% of people commence dialysis within 90 days of being referred to a renal service. and that has been associated with poorer outcomes in patients. I'm just going to go back one slide because I did accidentally skip past it. But the other reason why CKD is important is because it's obviously quite harmful as well. And you can see here that as a cardiovascular risk factor, CKD is the strongest independent cardiovascular risk factor. And in fact, it's a stronger cardiovascular risk factor than diabetes, than blood pressure, than cholesterol, than smoking. And so CKD leads to, overall, for all patients with CKD, leads to a 2 to 3-fold greater risk of cardiac death than people without the condition. CKD obviously has a significant impact on not just the patient, but also on their work, their family, and their psychosocial well-being. And this is a figure that I think in the bottom right, you can see here that most people don't recognize, is that around 65 Australians die every day with kidney disease, which is more than patients with breast cancer, more than patients with prostate cancer, and more than patients who die from road traffic accidents. So the next poll question is, does your practice have a chronic disease nurse? And I am going to come back to those answers soon, but I guess the reason why I ask this is because when you manage chronic diseases such as chronic kidney disease, clearly you need a whole of practice approach. And whilst the obvious answer is that the GP and the patient are important aspects into managing any chronic disease such as kidney disease, but also there is an important role to be played by the primary healthcare nurse, practice staff, and also by the data systems that you have available as well. And there are MBS item numbers that are available that help you achieve this. But also through this whole of practice approach, there are patient-led behavioral changes and lifestyle management approaches that can be achieved via all of these different aspects of the whole of practice approach. In terms of your role as a GP that may be of benefit, obviously you have primary care responsibility for the patient, and you can help support and assist patients in managing their CKD, looking at health promotion, disease prevention, managing the issues and complications of CKD, and also screening for problems and comorbidities associated with CKD as well. But it's important that you also act as a patient advocate. You coordinate care provided by others, and obviously you are aware that there's a team care management item number as well. And also it's important to maintain an ongoing relationship with the patient and their family to ensure that they have the best possible outcomes. In terms of the primary healthcare nurse or practice nurse, you can take the lead in terms of identifying patients at risk. So you can be involved in screening patients for CKD. You can also help support patients in terms of providing self-management strategies, facilitating patient-centered care planning. Motivational interviewing is very important in terms of chronic disease management, including CKD. And you can also provide education, support, and also obviously continuity of care. So does your practice have a chronic disease nurse? And so you can see here about 35% of patients of practices do, and about 64% of practices don't. But regardless, I think it does require a whole of practice approach, and perhaps a chronic disease nurse might be of benefit for your practice. This is a graph which we've shown for many years over the years. Sometimes it's been shown as an iceberg, and I'm sure you would have been familiar with it. But I think what it really underlines to you is that when most people in the community think about kidney disease, most people think of only the tip of the iceberg or the top of the pyramid as shown here, which is the dialysis and transplant population of only about 25,000 people in Australia. But if you think of that, there are a number of people with much earlier stages of kidney disease, stages 1 through to 5, and many of these people are actually unaware that they have CKD. So only less than 10% of people are aware they have CKD. Underpinning all of this is about 1 in 3 adults, or about 5 or more million people in the Australian community who are at risk of CKD. And particularly these people have risk factors such as high blood pressure and diabetes, but also obesity and other risk factors as well. There's a few important aspects of CKD risk factors which it's important to understand. And one of these is firstly age. And you can see here this from American data, and I can also show you data from the Australian Institute of Health and Welfare that similarly shows that there is an age-related increase in terms of the number of patients with kidney failure who are treated for kidney failure. So as patients get older, there is an increased prevalence. But I think it's also important to understand from this graph is that in the gray shaded top area that you can see is that there's a number of patients who don't actually have dialysis or transplantation, but they still have kidney disease, and it's still very important to understand these patients and manage and detect these patients as well, because they have significant morbidity and mortality and complications related to their kidney disease as well. It's also important, I just wanted to talk about the increased risk associated with CKD, and you can see here, this is data from the CKD Prognosis Consortium from Andrew Levy's group. And you can see here, this is very important data to show that in the graph, that as eGFR declines going from right to left on the horizontal axis, that the hazard ratio, or the risk of cardiovascular mortality increases significantly as the eGFR declines. But also, as you can see here, that you have in the blue versus the green versus the red, we have normal albuminuria, microalbuminuria, and macroalbuminuria. You can see that there's a multiplicative effect of having increasing amounts of protein as eGFR declines as well. And that even in patients who have what you would think is a normal eGFR, so at least GFR of over 60, you can see that the risk of cardiovascular mortality increases regardless of whether the patient has a GFR of 90 versus a GFR of 30. It still has an effect, just the presence of proteinuria. If you look at end-stage kidney disease, this might seem very obvious, but as your eGFR declines, your risk of end-stage kidney disease requiring dialysis or transplant also increases as well. But similarly, the presence of proteinuria, the more proteinuria you have going from normal albuminuria to microalbuminuria to macroalbuminuria, also increases your risk of end-stage kidney disease as well. And then if you look here, I think this is an important aspect. This graph basically shows you the relationship between creatinine and eGFR. And as you may or may not remember, that there is not a linear relationship between creatinine and eGFR. So what this basically indicates is that you can see here with the blue line is the creatinine, and then in the dotted line is the normal creatinine level. And you can see here that the creatinine level becomes abnormal down to an eGFR down here, perhaps somewhere between 45 and 60. But if you wait for the creatinine to become abnormal, you will have missed a number of people with earlier stages of CKD. And so this is why eGFR is important, because it helps you identify patients at an earlier stage of chronic kidney disease. And so this is also shown in this graph here, that what happens when you use eGFR measurements for CKD staging, it leads to early detection and management. As a result, you can slow the progression of the disease, you can prevent complications, reduce cardiovascular risk, and also reduce more significant morbidity and mortality associated with CKD. There are some caveats with regards to eGFR though, and so there are some situations when you need to think about whether the eGFR results may be misleading. These can be in patients with acute changes in kidney function, so acute kidney injury, people on dialysis, people with exceptional dietary intake, so people on high protein diets, and sometimes I've seen bodybuilders and people like that who are on high protein diets, or people on creatine supplements, people of extremes of body size, whether they're very, very small or very, very big, people with diseases of skeletal muscle, paraplegia or amputees, because it may affect the amount of creatinine that they have in their body. Children under the age of 18, the eGFR equations using the CKD epi equation is not advised to be used, and there's a separate formula called the Schwartz formula that we use. Patients with severe liver disease, eGFR is greater than 90. Also patients who are on drugs that interfere with creatinine excretion. And so most commonly I would see patients on trimethoprim, commonly used for UTIs, but this actually interferes with creatinine excretion as well. And also patients who are pregnant as well, the eGFR needs to be looked at with caution. With regards to drug dosing, eGFR, well, GFR measurement is important. Traditionally, a lot of people have used the Cockcroft-Gault formula, and obviously dose reduction is important in patients who have reduced kidney function, depending on which drug it is. But there is very good evidence now that if you have a readily available eGFR measurement, as is automatically reported on pathology, that this is still a very good and useful measurement of estimating relative renal drug clearance in these patients. And so if that's available, as long as you take into consideration their body size, so if you have patients who are very big and very small, then perhaps you need to look at other means for assessing drug dosing. But for the majority of patients, eGFR is actually quite useful and quite valid for looking at drug dosing. Obviously, the other caveat for this is in drugs with a narrow therapeutic drug index, in which case you should use therapeutic drug monitoring or some other valid marker of drug effect. So you might think about aminoglycosides, CNIs, anti-epileptic drugs. In these patients, obviously, you need to use therapeutic drug monitoring. In terms of the aspects or the elements of the kidney health check, there are important aspects. And the first aspect I'd like to talk about is urine testing. And so the preferred method for assessment of albuminuria in both diabetics and non-diabetics is a urine albumin to creatinine ratio, preferably in a first void morning urine sample. But if it's not available, obviously if patients turn up to your surgery at 2 o'clock in the afternoon, then a random, should be spots, not sports, but a random spot urine specimen for urine ACR is quite acceptable. In which case you should preferably measure a first void morning urine sample in these patients on the subsequent occasions, if possible. There is an association between albuminuria and progressive kidney disease in population studies. And it has also been shown, as I think I've already shown you in graphs, that the severity of albuminuria is predictive of outcome, not just of their kidney disease, but also of their cardiovascular disease as well. And that's been shown to have a renoprotective benefit in intervention trials, in addition to the observational sorts of studies that have been published previously. As mentioned, an initial urine ACR should be repeated on a first void urine sample if possible. You can also do urine ACR measurements on point of care testing machines. Albuminuria is classified as present if it's present in at least 2 out of 3 urine ACR results. And CKD is present if albuminuria persists for at least 3 months as well. And so one of the things that I often tell doctors and patients is that one swallow doesn't a summer make. So if you have a patient with an abnormal test, whether it's a creatinine result or whether it's a urine ACR, the next thing to do is to repeat it, not necessarily to refer the patient on, obviously depending on the patient's clinical predisposition. But in general terms, one swallow doesn't a summer make, and you should look at repeating these tests. Dipsticks are not recommended for urine protein testing because they're not as sensitive and they're not as specific as during a urine ACR result. And this table, I don't want you to take too much from this. I think it can sometimes be a little bit confusing, but we talk about normal albuminuria, microalbuminuria, and macroalbuminuria. We do have male and female differences because of muscle mass and those sorts of things. But I think in general purposes, I think of a urine ACR of less than 3 being normal, 3 to 30 being microalbuminuria, and greater than 30 being macroalbuminuria. And this equates to urine protein over the course of the day of, if it's over 30, it's between 50 to 500 milligrams per day. If it's over 30, it's equivalent to about 500 milligrams of proteinuria per day. If it's over 70, a urine ACR is equivalent to about 1 gram of proteinuria per day. And if it's over about 230 milligrams per millimole, then it's equivalent to about 3 grams per day, or what we would call nephrotic range proteinuria, such as in patients with nephrotic syndrome. These are the important types of numbers that I look at. I guess one thing to say is that sometimes we do look at the urine protein to creatinine ratio, and one of the values of this is that if you multiply the urine protein to creatinine ratio in milligrams per millimole by 10, it's roughly equivalent to the number of milligrams per day. So a urine PCR of 30 is equivalent to about 300 milligrams of proteinuria per day. In terms of blood pressure, so we now have a new blood pressure target. And I know that you would be aware of the fact that there are a number of different blood pressure recommendations and significant blood pressure trials that have been published over recent years. So what we've basically looked at is recent evidence and guidelines, both locally and also internationally, and also not just with regards to kidney disease, but also with regards to blood pressure management in heart patients and diabetic patients as well. And so we thought that the simplest and the most practical way of of putting this together is that all patients with CKD should maintain a blood pressure below 130/80, irrespective of the amount of proteinuria, irrespective of whether patients are diabetic or not. But obviously we do have a caveat that treatment should be individualized, and in some patients, perhaps it may be appropriate to aim for a lower blood pressure target, such as if they have an extremely high cardiovascular risk, or patients perhaps if they have very significant proteinuria as well. But in general, we suggest that all patients with CKD should have a blood pressure below 130/80. So to take it further, I just wanted to talk to you about a case study. So this case study is Rita. And Rita is a 63-year-old accountant, and she has a history of mild asthma, and she's new to your practice. She's overweight or obese with a BMI of 31. She has mild asthma, chronic low back pain, and mild hypertension. She has a maternal grandmother who died of a heart attack in her 60s, but also had a history of what she thought were kidney problems, but you don't know any other details about that. She has a mother who had type 2 diabetes or has type 2 diabetes, and her father has heart disease with angina and also high blood pressure as well. Rita is a smoker, probably by virtue of the fact that she's an accountant. And otherwise, she has a 25-pack year history. She drinks alcohol, 1 to 2 glasses of wine, 3 to 4 nights per week. She has no known drug allergies, and she uses a salbutamol inhaler as required. So the first question I'll put to you, which I'm not asking for a poll, but I want you to think about, does Rita have an increased risk of chronic kidney disease? And so, as I've mentioned before, 1 in 3 Australian adults are at increased risk of CKD, and we now talk about 9 risk factors for CKD, all of which increase the risk of CKD by at least 20% each. So these are very common risk factors, and you can understand when you look at these risk factors why 1 in 3 Australian adults have these. These include patients with diabetes, high blood pressure, patients who are obese with a BMI in excess of 30, patients with established cardiovascular disease with a family history of kidney failure, patients who are smokers, over 60, Aboriginal and Torres Strait Islander descent, and also patients with a history of acute kidney injury as well. Each of these risk factors significantly leads to an increased risk of CKD. And if you think about Rita, she has high blood pressure, she has possibly a family history, but she certainly has a BMI in excess of 30. She's a smoker, and she's also over the age of 60 as well. So she has at least 4 of the risk factors for CKD. So the next question is a poll question. So I want you to think about what are the elements of targeted assessment for CKD in at-risk groups. Serum creatinine and eGFR, renal imaging, blood pressure measurement, urine protein to creatinine ratio, urine dipstick measurement, or urine albumin to creatinine ratio. Okay. So talking about her risk factors, I just wanted to, and I will come back to the poll question as I've mentioned before. So talking about her risk factors, diabetes is important. Diabetes is common also, but also up to 30% of patients with diabetes eventually develop CKD at some stage. And as you probably know, about 1% of Australian adults, or adult Australians, develop diabetes each year as well. High blood pressure and kidney disease are intimately linked, and there's a bidirectional relationship between the two. And so as you can see here that kidney disease can cause high blood pressure, and blood pressure can also cause kidney disease as well. In terms of obesity, this is a study from America, which basically looks at body mass index and the development of CKD. And you can see here that in patients with a BMI in excess of 30, to the right here, that they have a significantly increased risk of CKD. And in this study, it was CKD as defined by an eGFR of less than 45. And so you could argue that patients with an eGFR of less than 60, it's obviously even more than that. In terms of smoking, this is another study from the same authors. and basically looked at patients with cigarette smoking. At least 25 pack years leads to a significant increased risk of CKD as well. If you look at the Aboriginal and Torres Strait Islander descent, this is data from the Australian Institute of Health and Welfare. And you can see in the bold columns, you have the non-Indigenous population. And in the green columns, you can see the Indigenous population. Overall, there's at least a 4 to 6 times increased incidence of CKD in the Indigenous population compared to the non-Indigenous population. In terms of acute kidney injury, CKD can lead to acute kidney injury, and also acute kidney injury is a risk factor for CKD as well. And you can see here that these are patients with episodes of acute kidney injury. Many patients with acute kidney injury lead to repair and resolution of their kidney disease, but a number of patients, particularly as they have ongoing episodes of acute kidney injury, lead to increased risk of chronic kidney disease in the end. And so you can see here that the risk of developing end-stage kidney disease is enhanced about 4 times by superimposition of acute kidney injury in CKD patients. And also it's important that acute kidney injury is an important predictor of poorer outcomes in these patients as well. So in terms of Rita, what would you do next when you've found that she's got these risk factors? This is a rhetorical question. And so with Rita, you would suggest that she should have a kidney health check. And then depending on what her results are, if she's negative, then maybe she should have a kidney health check every year. So this is going back to the poll question. What are the elements of targeted assessment of CKD in at-risk groups? And I've already talked about it. So it's basically what we call a kidney health check. This is what everybody says. Most people say eGFR measurement, creatinine and eGFR. Some people say renal imaging. Most people say blood pressure measurements. Some people say protein to creatinine ratio, but more people say urine albumin to creatinine ratio as well. And I guess protein to creatinine ratio is not wrong. It's just that albumin is the predominant protein in the urine, but it doesn't equate for all protein in the urine. It's usually about 75% of all protein in the urine. So therefore, if you look at urine albumin to creatinine ratio, you're going to pick up patients at an earlier stage of disease because you'll pick it up with increased sensitivity compared to urine protein to creatinine ratio. Urine dipstick does not have as good a sensitivity as a urine protein to creatinine ratio. So therefore, urine albumin to creatinine ratio is important as well. Kidney imaging is important, but it's probably not the most practical in terms of the fact that you can't do this as screening for whole populations. It's obviously, there is an expense associated with it. And so in terms of easy kidney health check sort of measurements, we recommend the 3 pillars being blood pressure measurement, urine measurement for ACR, and also blood tests for serum creatinine and eGFR measurement. And this is basically what I indicate here: kidney health check, blood test, urine test, blood pressure check, and that patients at risk should have a kidney health check every 1 to 2 years. So going back to Rita, these are the results that you find in her kidney health check. You can see her creatinine is 118, which provides you with an eGFR of 55. She has microalbuminuria with a urine ACR of 5.7, and she has a blood pressure that's elevated at 155/95. So do Rita's kidney health check results mean that she has chronic kidney disease? Again, a rhetorical question. Not yet. And so as I mentioned before, it has to be proven that she has chronic disease in the first place. So it has to be consistent over at least 3 months for you to be able to diagnose CKD. If the first urine ACR is random, then you should repeat it ideally as the first void more in your urine sample. And as I mentioned before, 1 swallow doesn't a summer make. So depending on the urine result and also the creatinine or eGFR result, you should look at repeating these tests over a 3-month period as well. There are also caveats in terms of urine albumin to creatinine ratio. So there are some factors that can lead to a falsely positive or increased urine ACR. These include a UTI, heart failure, febrile illness, heavy exercise, genital discharge, also drugs, particularly non-steroidal anti-inflammatory drugs. So Rita comes back to see you a couple of months later with repeat tests for the urine ACR, eGFR, and you check her blood pressure as well. And these are the results you get. And you can see that they're quite similar, that her eGFR remains low at 52. She still has microalbuminuria, and she still is hypertensive as well. So what's your next step with Rita? So this is the CKD staging classification that hopefully you are aware of. And so we used to have a CKD staging classification basically looking only at EGFR, but we now recognize, as I've already shown you, that the amount of proteinuria or albuminuria is actually important in terms of the outcomes for patients, morbidity or mortality. And so you can see here, we now have a CKD staging classification based on albuminuria and kidney function or EGFR stage as well. So we have CKD stages 1 through to 5, with 3 split into 3A and 3B, recognizing the fact that patients with an EGFR between 30 to 44 have a significantly different outcome compared to patients with an EGFR of 45 to 59. But also with an albuminuria stage going from normal albuminuria to microalbuminuria to macroalbuminuria. And so with Rita, you can record her CKD diagnosis as CKD stage 3A with microalbuminuria. And so how does this help you? Well, now you can go to your CKD management handbook or to the CKD Go app. And in there, you will find the color-coded classification. And in there, you will find an appropriate clinical action plan, depending on which part of the staging classification the patient fits into. And so, as you can see here, if she fits into the orange clinical action plan, you'll do both the yellow and the orange. You'll do investigations to determine the underlying cause. You'll look at ways of reducing the progression of kidney disease. You'll look at her cardiovascular risk, and you'll see ways in terms of avoiding nephrotoxic medications or avoiding volume depletion as well. And you'll look at how to detect and manage the complications, her medications, and you'll consider when it might be appropriate to refer her onto a nephrologist. And this is all basically summarized here, but just to highlight to you again that this is all available in the CKD Management Handbook, but also in the CKD Go app as well. And then we also have management strategies here, depending on what you find in terms of the frequency of review, how often to assess the patients, and what to assess for in these patients as well. So rhetorical question again, as Risa's GP, how do you reduce her risk of cardiovascular disease? So in terms of cardiovascular risk reduction, CKD, as I've already talked about, is a potent risk factor. And so it's important in terms of cardiovascular risk to use a cardiovascular risk management tool such as the CVD check as we have available in Australia. And it's important to understand that with CKD, an individual's cardiac death risk increases 2 to 3-fold compared to patients without CKD. And in patients with CKD, I think this is something that is not well understood, but individuals with CKD are 20 times more likely to die from cardiovascular disease than survive to need the dialysis or transplant. It's still important to manage these patients in terms of their CKD, and this is what we're doing in terms of managing their CKD. We're also looking after their cardiovascular disease as well. But the reason why we don't ask patients to be referred on at all stages of CKD is because they don't necessarily need to be referred in terms of dialysis or transplant management, because many of these patients don't actually get to that stage. In terms of cardiovascular risk, it's important to understand that certain patients are already at the highest risk of a cardiovascular event, and therefore the CVD check calculator shouldn't be used. And these include patients with an EGFR of less than 45 or with persistent proteinuria, diabetes and microalbuminuria, diabetes and age over 60, patients with established cardiovascular disease, cholesterol over 7.5 or familial hypercholesterolemia, or patients with severe hypertension over 180 over 110. In terms of blood pressure reduction, I've already told you about the intimate links between blood pressure and CKD, and obviously getting blood pressure to below target levels is one of the most important goals in terms of blood pressure CKD management. Our first line recommended therapy would be an ACE inhibitor or angiotensin receptor blocker. We do not recommend combined therapy with ACE and ARB, but we do recommend that the maximal tolerated dose of ACE or ARB should be used in patients. Blood pressure that may be difficult to control, though, may be difficult to control in many patients. And sometimes in many patients, you might require 3 or 4 medications to treat these patients. So in terms of Rita, what you should be trying to do is use an ACE or an ARB to maintain a blood pressure consistently below 130 over 80. Now, it's important to understand that an ACE or ARB, by virtue of the fact of how they affect the afferent and efferent arteriole in the glomerulus, can lead to a reversible reduction in glomerular filtration rate. So if there is a reduction of less than 25% and it stabilizes within 2 months of starting therapy, we still recommend that you should continue the ACE or ARB, because there's very good evidence that in these patients, they still benefit in terms of reduction in or slowing the progression of their renal disease, and also in terms of their cardiovascular event rate as well. But if the reduction in EGFR exceeds 25% below the baseline value, you should consider stopping the ACE or ARB, and you might even consider referring to a nephrologist at that stage for assessment for bilateral renal vascular disease. But in general terms, they probably don't need to be referred. In general terms, if they have a GFR decline over 25%, then you should just stop the ACE or ARB. So what we would normally recommend is that when you do start an ACE or ARB, you should do a patient's UEC 7 to 10 days after starting the medication to look for declining kidney function, but also to look for their serum potassium level that can sometimes increase as a result of the medication. And it's been very clearly shown in terms of blood pressure management, the benefits of management. And you could see here, this is a paper from George Bakris's group, meta-analysis, looking at different blood pressure targets, 160/95, 140/90, and 130/85. And on the vertical axis, you can see the GFR decline of up to 12 mils per minute per year in patients with CKD. And you can see here that in patients with uncontrolled blood pressure, such as Rita, that she may have a decline in kidney function of 10 or more mils per minute per year, but that if you get her blood pressure down to a target of below 130/85 in this instance, that you can significantly reduce her or slow the progression of her kidney disease as manifest by the decline in EGFR on a yearly basis. In terms of lipid lowering, there's good evidence for looking at the lipid management, and because obviously lipid management and cardiovascular risk is associated, lipid lowering treatment should be considered for CVD risk reduction. Glycemic control is also a very important pillar in terms of the management of patients with diabetes and kidney disease. And it's been very clearly shown that in both type 1 and type 2 diabetic patients, that good glycemic control leads to a slowing of the progression of kidney disease, but also in a reduction of cardiovascular events and overall mortality as well. In terms of self-management, there are a number of different self-management principles which are important in terms of managing patients. These are about allowing the patient to set appropriate and achievable goals, using evidence-based or planned care, engaging the patient in decision-making and also management of their illness, using patient self-management support tools, and obviously using a team approach in terms of managing care of these patients. And I've already talked to you about the value of using your practice nurses or primary healthcare nurses in the management of these patients. Lifestyle modifications are important in all chronic diseases, and no less so with chronic kidney disease as well. And in terms of lifestyle approaches, many of the lifestyle approaches we recommend are basically based on the SNAP principles, which is looking at smoking or stopping smoking, nutritional modifications, including a low-calorie diet and particularly a low-salt diet, a moderation of alcohol intake, and also healthy physical activity in patients as well, all of which hopefully lead to achievement of a healthy body weight in these patients. I just wanted to take a few moments to look at acute kidney injury, and one of the mnemonics we use is what we call SADMANs, if you haven't heard of it before. So these are medications and circumstances when patients are at increased risk of acute kidney injury, and if patients are in circumstances where they may be unwell with a fever and have reduced oral intake, you would perhaps advise patients to cease these sorts of medications, all of which collectively may lead to acute kidney injury. So these include sulfonylureas, ACE inhibitors, diuretics, metformin, angiotensin receptor blockers, NSAIDs, and now also SGLT2 inhibitors as well. All of these should be considered to be stopped in patients who are unwell, and particularly with oral intake reduction as well. So poll question, in your practice, who gets referred to a nephrologist? Is it everyone who gets diagnosed with CKD? Everyone with CKD and diabetes, patients with CKD and high blood pressure, patients with a rapid decline in kidney function, or patients who need to start dialysis soon? Which patients do you think should be referred to a nephrologist? Okay, we might move on there. So I guess this is relevant because you might be asking, well, should Rita be referred to a nephrologist? And I guess obviously appropriate nephrology referral can be associated with very positive outcomes in terms of morbidity, mortality, reducing the rate of progression to end-stage kidney disease, timely preparation of permanent dialysis access. In some patients, they may require kidney transplant, and obviously by referral to a nephrologist, it may increase their likelihood of kidney transplantation, but also the need for and duration of hospitalization as well. So in terms of in your practice, who gets referred to a nephrologist? Have we got the answers there? So it's a bit of a split, but particularly patients who have rapidly declining kidney function, most patients would get referred, and patients who need to start dialysis soon. But it's a little bit less clear as to which of the other patients should be referred. And I guess I'd put to you that not all patients need to be referred to a nephrologist, regardless of whether they have diabetes or high blood pressure. And so these are the patients in whom we would recommend nephrology referral. Patients who have an eGFR of 30, because in patients who have an eGFR of in excess of 30, without these other metrics shown here, but in excess of 30, they're probably more likely to have a cardiovascular event than to require renal replacement therapy, meaning kidney dialysis or transplantation. If patients have a persistent significant albuminuria, meaning a urine ACR of in excess of 30, they should be referred. If they have a sustained decrease in eGFR of 25% or more within a 12-month period, so a more significant decline in kidney function than we would expect, or a sustained decrease in eGFR of more than 15 mils per minute per year, these patients should be referred because they're progressing more rapidly than you would hope. And then obviously if you have patients with CKD and high blood pressure, that's hard to get to target despite at least 3 antihypertensive agents. So patients on the other side who don't necessarily require referral are patients with an eGFR of in excess of 30, urine ACR of less than 30 with no hematuria. So if they have hematuria and proteinuria, that might indicate that they have glomerular disease and they might still need to be referred. But if they have no hematuria, and also patients with controlled blood pressure. But obviously you need to individualize the circumstances, and in certain patients you might need to refer patients on regardless of the circumstances. But these are our general guidelines. In terms of treatment targets, these are obvious, I guess, from what I've already said. So blood pressure target of less than 130/80 using lifestyle modifications and ACE or ARB. Albuminuria, we aim for albuminuria to lessen an in excess of 50% reduction of their baseline value. So at least a halving of their albuminuria. Total cholesterol of less than 4, LDL of less than 2 through a combination of dietary advice and or statins. And sometimes also there's evidence for the use of ezetimibe with statins as well. And also blood glucose control, we recommend an HbA1c of less than 7% or less than 53 millimoles per mole using standardized international units. And this is using lifestyle modifications or anti-hyperglycemic agents or insulin as well. In the case of Rita, what difference do you think a diagnosis of CKD makes if you already manage your patients well? Well, again, this is a rhetorical question, and I guess the important things about diagnosis is that it may set to you different treatment targets and therapy choices according to their CKD diagnosis. Importantly, it can lead to earlier detection and management of their complications of CKD, and therefore also lead to a better prognosis for these patients. And also, as a result of CKD, it may lead to different dosages and more appropriate dosages of prescribed medications for kidney patients, but also avoidance of nephrotoxic medications. And then obviously, depending on the circumstances, it may lead to more timely referral of CKD patients to a nephrologist. So in terms of addressing CKD in your practice, I think it's important to think about kidney disease when you do consider other chronic diseases as well. And there are MBS item numbers and there are opportunities for you to identify these patients earlier. To do this, you can use CKD Handbook or the CKD Go app, but also you can use practice data to identify patients. And I know that the majority of practices around Australia do have patient management software, and there are tools that are available through your practice management software that can help you identify patients earlier. And you might consider therefore using a system to register and recall patients who have risk factors for CKD so that you can therefore screen them and assess them appropriately. And as a result, you can also have a screening survey in your waiting room and you can refer patients onto the appropriate referral system if necessary. So I just wanted to wrap it up at this point. I know I've only got a few minutes left to basically highlight to you that CKD is important because it's common, it's harmful, but as I said, the blue sky aspect is that it is treatable. Early detection is beneficial in these patients, and it's important in terms of early detection to therefore know what the risk factors for CKD are. And the way that we detect CKD is through a kidney health check, looking at urine ACR, eGFR measurement, and a blood pressure check for at-risk patients. It's important to understand the blood pressure targets that we're looking at now, 130/80. It's important to understand the CKD staging classification, and that there are clinical action plans developing that have been developed that help you according to the CKD coding classification that is available in the handbook. And most patients can actually be managed in general practice. So you can, the CKD management handbook can be downloaded via the Kidney Health Australia website. There's a PDF copy that's available for free. There's also a tax deductible hard copy that can be bought from the Kidney Health Australia website, and it can be a very handy resource to have in your practices. And there's also the CKD Go app that can be downloaded for free on Google Play and also on the iPhone stores as well. There are also patient resources, and the one that I probably use the most is the Kidney Health Fact Sheet. So these can be found on the Kidney Health Australia website. There's also a handbook available for patients and also an app called My Kidneys, My Health. And then finally, there is a kidney helpline where patients can ring to Kidney Health Australia and ask for any questions or advice as well. If you want to find out any more information about CKD, there's a Think GP learning module that's available. And also we do have a number of different learning modules that we've developed with the PIC committee. And so we can, if you get in touch with your team, we can also liaise with you and with them with regards to interactive webinar sessions as well. So I'd just like to ask everyone if you can complete the evaluation form that will be made available to you. I'd also ask if you can get a copy of the new handbook. I think you will find it very, very informative. And there are also social media ways of connecting with Kidney Health Australia as well to get up-to-date information. So please do click on the link to go to the SurveyMonkey evaluation. I'm sure Robbie and the whole of the Sydney North Health Network would be very happy if you are able to do that for us. Thank you.
Thank you, Richard. We have 2 questions that have been sent through.
Yes.
The first one is, are there guidelines for renal function normal ranges according to age for adults in the handbook?
Yeah, no, that's a really good question. So the question about age and CKD staging classification, in years gone by, we did have an age classification or caveat with regards to eGFR measurement. We don't have that anymore because what's quite clear to us is, yes, we understand that as we all get older, unfortunately, as we all get older from about the age of 40, eGFR does decline. But there's very good evidence that even if you have an eGFR of 50, 60 or whatever, that patients who have a reduction in eGFR still have an increased number or risk of comorbidities and complications associated with CKD. And so therefore, it's still important to understand that these patients do have CKD and manage these patients appropriately. So we don't have embedded into the CKD staging classification an age, a guide to that, because it's still important whether patients are 80 or 90 years of age, even if they have an eGFR of 50, it still is associated with complications in those patients. And the other question?
Yes, it's more of a statement, I think, maybe for comment. I referred a patient to Royal North Shore Hospital with eGFR 40 to 45, urine ACR 12 to 20, female, declined by nephrologist because not meet criteria.
Well, I can answer this question because I don't work at Royal North Shore Hospital. But look, I guess if you look at the guidelines that I provided to you, yes, they don't fit the criteria for what we recommend for referral guidelines. And in this sort of patient, yes, this patient does have, presuming that this is present for at least 3 months, this patient does have evidence of CKD. We don't recommend that this patient necessarily gets referred onto a nephrology service. One, because this patient is unlikely to require dialysis or transplant. But 2, because all of the things that we would do for this patient is is achievable in primary healthcare. That being said, you know, I get patients referred to me like this as well. And obviously it's a numbers game as well. And if we saw every single patient with kidney disease, we would be overrun. But if there's a clinical reason where you are concerned, or if you're not comfortable looking after a patient, I think by all means, contact your nephrology service. Perhaps in that circumstance, you could perhaps even ring the hospital and ask, what do I do with this patient? You know, and perhaps they might give you some advice. The first advice I would give you is have a look at the CKD Management Handbook, or look at the CKD Go app. And I think you'll find that there are many things that you can look at which you can manage in primary healthcare.
That sounds like a good answer to end on. So thank you, Dr. Richard Foon, for your time this evening and this very informative webinar. To everybody that's attended, please make sure you just set aside a moment, if you can, for the SurveyMonkey evaluation at the end of the webinar. If anybody has phoned in, you will receive a reminder email tomorrow with a link to the evaluation. And thank you to everybody for attending this evening. I hope you found it very beneficial. Good night.
Thank you, everybody. Good night, everybody.